Okay, so we'll like to move to the penultimate talk of this session. This will be by Dr. Corte, titled "The Rise in Pulmonary Blood Flow During Exercise is Reduced in Pulmonary Hypertension."
Thank you, and thank you particularly to Luca and the organising committee for organising such a fantastic conference and for asking me to speak on this work, which I did at the Brompton Hospital along with some colleagues of mine who are here, including Professor Wells. And I should just say that I'm now working in Sydney, Australia, but this is work which was done at the Brompton Hospital. So sorry about that. Not quite sure what happened, but it seems to be working again. So let's just see if this works as well. No, okay. All right. So I'm also taking a more clinical route here. So we're moving away from the molecular biology, looking at the pulmonary vasculature in idiopathic interstitial pneumonia. So, okay. So you will all be very aware, no doubt, that the current definition of pulmonary hypertension is based on that of right heart catheter, so having a mean pressure of greater than 25, a wedge of less than 15. And you'll also be aware that pulmonary hypertension is common. Thank you. Thank you. Is common in idiopathic interstitial pneumonia, and these figures that I've got here are from for IPF, where the prevalence ranges greatly from around 30 up to 86%, depending, of course, on how you measure pulmonary hypertension and when you measure it in the course of the disease. And we looked at patients across all interstitial lung disease and showed that having pulmonary hypertension, but particularly having a high pulmonary vascular resistance, was predictive of a high short-term mortality. So, maybe I should just tell you the results of my study without the slides. I'm sorry, it's not working again. Are you able to do that? I think perhaps I should just talk. Yeah. Yeah. I'll try and give you the talk without the slides. Oh. Okay. Yes, this one. Fine. This will do. Yes. So the problem that we have in diagnosing pulmonary hypertension is that we can only really pick it up with right heart catheter until it's too late, until the pressure is actually high. As you know, the pulmonary vascular circulation is a low resistance circulation with high capacitance, and as the pulmonary blood flow increases, you get increased recruitment, increased distension of the capillaries, but the pulmonary arterial pressure only rises after about 50% of the pulmonary vascular bed has been destroyed. So the current definition of pulmonary hypertension is insensitive for the early diagnosis of pulmonary vascular disease, and in our patients it is often diagnosed too late, and when, of course, you know, there is very limited intervention. So we looked at exercises which are clear stress of the pulmonary vasculature, and we know that people's pulmonary arterial pressure goes up with exercise. And it has been suggested that elevation of the pulmonary arterial pressure during exercise might be something which precedes that of overt pulmonary hypertension or elevation of the pulmonary arterial pressure at rest, and that perhaps it might be a marker of early pulmonary vascular disease. So pulmonary blood flow, that's what we were looking at. We used the Innercore machine, which you may be aware of is a machine made in the Netherlands by Innovision, which is a inert gas rebreathing device which uses photoacoustic gas analysis to work out the pulmonary blood flow. And and therefore the cardiac output, which is assumed to be the same as the pulmonary blood flow in absence of shunting. So we already looked at this at rest compared to the right heart catheter, and we showed that was, although you might think it might not be reliable in interstitial lung disease, that it was relatively good test at rest. And we know that this test can be done during exercise, so we set out to try and do that. And this you may recognise as a respiratory physician at the Brompton Hospital who is helping me by posing as a model here to show how it's done. And you can see this is a simple mouthpiece, a rebreathing bag, and a portable machine. There's oximetry, and these are the sort of things that we get. So it looks at a soluble gas and an insoluble gas and the gradient of those two over time. So we hypothesised that Firstly, it was feasible to do in our patients, which is something you might think might not be feasible to do in our patients, put them on an exercise treadmill and to do this test during it, but we've hypothesised that it was, and that the rise in pulmonary blood flow or cardiac output would be lower in those with pulmonary hypertension compared to those with idiopathic interstitial pneumonia and normal controls. In the same study, we looked at BNP and the rise in BNP, brain natriuretic peptide, during exercise. Okay, so we set out to look at the rise in the pulmonary blood flow and the rise in BNP during exercise test in these patients. So how do we do that? We looked at, it was a small study, pilot study, we looked at 10 patients in 3 groups, 10 IIP patients, so 8 with IPF, 2 with fibrotic NSIP, and these patients didn't have pulmonary hypertension on echo, and there were no, there were patients where we didn't think that there was any earlier pulmonary vascular disease, so pure fibrotic patients as much as we could tell. Pulmonary hypertension patients, again, 10 of these diagnosed at right heart catheter, and they were patients with pulmonary arterial hypertension or chronic thromboembolic disease. We excluded those with Eisenmenger syndrome, clearly because there was shunting, and there's a problem with the test, and 10 normal subjects. And they all came in for a single day testing where they had baseline pulmonary function tests, they had a resting BNP level done, and then they had resting pulmonary blood flow, and we took the mean of 3 measurements. And then they had an exercise test. So the normal controls did the Bruce protocol on the treadmill, the patients did the modified bulk protocol on the treadmill again, and the pulmonary blood flow was measured during this time at 3-minute intervals, and then the patients were asked to give a warning just before they stopped, and a measurement was done just before they stopped exercise. Then we did serum BNP in the first 2 minutes of the recovery period. And these are the results. So you might well expect that patients with IIP had worse lung function compared to pulmonary hypertension and normal controls. In terms of the resting pulmonary blood flow measurement, there was no difference when all of the groups were compared together. When you specifically compared IIP patients to normal controls, the IIP patients had a slightly higher resting pulmonary blood flow. But resting pulmonary blood flow was not a good distinguishing thing to use. And as, again, you may expect, a serum BNP at rest, the pulmonary hypertension levels were higher than what the patients with pulmonary hypertension had higher BNP levels than patients with IIP who had higher levels than the normal controls. So that's the same data there. So looking at the exercise results. So the pulmonary hypertension patients had a reduction in the rise of their pulmonary blood flow or cardiac output during exercise compared to both the normal controls and the IIP patients. That was true independent of their resting pulmonary blood flow, and it wasn't associated with their resting pulmonary blood flow. I think it's best shown here graphically. So you can see here that these are the normal controls, these are the IIP patients, and here are the pulmonary hypertension patients. Although there wasn't a significant difference at rest, you can see that the rise in pulmonary blood flow or cardiac output was less in patients with pulmonary hypertension. What about the other exercise parameters? Well, you may expect that the patients, both groups, did worse than the normal controls, but interestingly there was no difference in our patients in the exercise, the time of total exercise or the VO2 per kilogram, which I think is important. So they were achieving the same level of exercise. Also interestingly, but or previously shown, is that pulmonary hypertension patients had an increased VCO2 and a VCO2 compared to the IIP patients and the normal controls. Interestingly, there was no difference between the pulmonary blood flow increase compared to the IIP patients compared to the normal controls. So lastly, what about BNP? Well, the pulmonary hypertension patients had higher post-exercise BNP compared to the IIP patients, and again compared to the normal controls. And the rise in the BNP again was increased in the pulmonary hypertension patients. But in fact, it didn't give any additional information over that of the resting BNP. So resting BNP was already elevated. The rise in BNP didn't help us any further, unlike the pulmonary blood flow measurement. So you can see that clearly. So the pulmonary hypertension patients had high BNP at rest. It was again high at exercise. There wasn't much help to measure it after exercise. Here are the IIP patients, and here are the normal controls. So we wanted to see, was there a relationship between BNP and the pulmonary blood flow rise, and in fact there was a somewhat of a relationship between the resting BNP and also to the rise in BNP, but really when you looked at it, the rise in BNP didn't confer any additional information. So in summary, the relative increase in pulmonary blood flow or cardiac output is reduced in patients during exercise in patients with pulmonary hypertension compared to those with IIP and normal controls. That the resting and end exercise serum BNP is elevated in patients with pulmonary hypertension above that of IIP patients and above that of normal controls. And that the rise in pulmonary blood flow during exercise is associated with resting serum BNP, and again to the rise in BNP on exercise. So what can we conclude? Well, firstly, that it is a feasible test to perform. Did take a long time to do the study, but that wasn't the patient's fault. It is feasible with the right people and with the right support from the lab. So how is it useful? Now, it might be that this non-invasive measurement of pulmonary blood flow is a useful method to identify pulmonary hypertension or pulmonary vascular disease early in the course of its course. We, of course, have not measured pulmonary hypertension patients with IIP and pulmonary hypertension, which, of course, is the logical next step and something which we're going on to look at to see if, in fact, we can identify this process early. Or perhaps exercise and pulmonary blood flow on exercise is something which we can look at in terms of change over time. So 6-minute walk tests, as we know, are quite non-specific in terms of looking at change, but maybe this is something that we can look at and numerically assess in terms of change over time. So as I mentioned, there are ongoing studies are necessary to look at this even further. So just in conclusion, I'd like to thank the people who helped at the Royal Brompton Hospital and also where I work now at RPA and of course at Teleon as well. Thank you.
Thank you for that talk. Do we have any questions?
Yeah, I was just wondering why you used a different exercise protocol for your controls and your patients. I mean, I can understand why you might want to not give the boost to patients, but why not give the controls the same protocol?
We wanted to try and get their maximum. So we wanted to stress them. The modified bulk protocol you can do indefinitely, and we wanted them to be able to stop, and we wanted an peak exercise or an end exercise measurement of the pulmonary blood flow. So, I mean, I can go the bulk protocol for, hours.
But I guess if you show this bigger increase in pulmonary blood flow and controls, it's because they did more exercise.
But we didn't show.
I thought you showed they got an increase in the controls. Had an
increase. They had an increase in pulmonary blood flow, but yes, they did, but it was much. Sorry, yes, so but it was the same with the IIP patients as well. Yeah, I can see what you're saying. They exercised to higher capacity, they had higher VO2 per kilogram, but I guess we wanted to say this is the maximum, this is their stress, and yes, I mean, I expected their pulmonary blood flow would go up with exercise, but I take your point that it's not directly comparable, but even so, the pulmonary hypertension patients definitely had a reduction in the rise compared to the IIP patients or the controls, but yeah, point taken, thank you.
So do you think there's a role for exercise testing in management or prognosis for IPF patients?
Well, I think there is a role, and I know that a lot of people, some people here have published on it and looked at it. However, I'm not sure that any of us are completely confident of exactly what role it is in terms of, particularly with prognosis. But there certainly is a group of patients who do worse. But how we can work out that exact marker in terms of how to distinguish patients, I think it's tricky.
Hal?
Thanks, Tim. I had a just kind of general question and then maybe a suggestion for collaboration. So can you just comment on the importance of identifying pulmonary hypertension? I mean, I think this has been something we've tried to do non-invasively for a long time. It's been very difficult. So what are the implications, you think, of identifying that? I mean, there have been some trials that have been, it's been hard to show a benefit of treatment, but yeah. And then also, are there other ways of getting at this non-invasively, maybe with Toby's approach of biomarkers? And can you comment on any work you've done in that area?
Yeah, sure. So I think the first question with regard to how important is it and what can we do about it, I mean, I think it in my mind and theoretically, it would be important to try and identify these patients early so that we can try and intervene. But what intervention do we have? You know, clearly we haven't shown any so far. I know that a study of an endothelin receptor antagonist, which has been just completed at the Brompton Hospital and across the UK, will give some light on that. But as you say, there's not a lot in the literature, and perhaps something we can collaborate on. But in terms of how we can identify pulmonary hypertension non-invasively, I think that the problem is the gold standard. I mean, the right heart catheter is clearly the best thing to use, but perhaps we are identifying these patients too late, and what can we use? I mean, I think there is a role for biomarkers for sure. We've looked at a series of different non-invasive measures, not biomarkers except for serum BNP, but other things including overnight oximetry, walk tests, and echo tests, and other markers, and trying to put them in a sort of a model. And I know other people have published on this as well, and there must be a way of screening these patients for right heart catheter.
Well, thank you. I have more a comment. I think it's very important to discuss this point, and but the term pulmonary hypertension in this context may be misleading because it may identify much too late patients. So we should talk about a vascular involvement or pulmonary vascular phenotype.
Yes.
That is what we want to detect.
Yes, I totally agree with that. Thank you.
Okay.
Thanks.
Well, thank you very much for persevering with the presentation. Well done. So we...